my partner Max is going to walk us through a lot of fairly new information on tuberculosis and how it's affecting some people still nowadays, more than 200 years after the events of Les Miserables, and how we should be thinking about TB as a potential emerging risk in our risk management programs. But before we start, I wanted to remind you that nothing in today's podcast is meant to be investment advice. We hope to stimulate your thinking on risk management, and let's get started.
I try to write about an emerging risk about once per quarter. I have a list of potential topics, and it's really a challenge each time to pick a topic early enough so that a high level understanding is new to the reader. There's a developing Ebola outbreak in Congo and a strong El Nino expected starting soon that I worry will create food insecurity issues in some areas and water shortfalls in the U.S. Southwest. We're already seeing a heat wave in Europe. I've had tuberculosis or TB on my radar for several years. It ties in with antimicrobial resistance or AMR to expand that risk globally. As those of you who regularly scan for emerging risks know, once you see one, it means you notice it when others share research on the topic. And recently, TB has been a topic of increasing interest. Tuberculosis can be summarized through airborne transmission, asymptomatic spreaders, susceptible populations, and comorbidities. Getting developed countries and the pharmaceutical industry interested in developing a vaccine are all challenges. Despite over 1 million deaths globally each year, more than malaria, and its role in mortality for those with HIV, it has been challenging to fund research. This is probably because, although it is a communicable infectious disease, it is not prevalent in developed nations. This was not always true. TB was the leading cause of death in the US prior to the development of antibiotics, but limited research and increasingly drug-resistant strains make it an emerging risk to be aware of even in the US. In some ways, this is an update to my early 2023 emerging risk topic about antimicrobial resistance. Robert Koch first discovered the bacterium that causes tuberculosis, so it became known as Koch's bacillus. Treatment became available once antibiotics were discovered. TB is preventable and curable, but hard to detect and can lay dormant for many years. A fully effective vaccine is not yet available against Mycobacterium tuberculosis, and a full treatment, often a drug cocktail including rifamycin, requires 6 months to eradicate. A cure refers to eliminating the bacterium, but the damage done to lungs often is permanent. Latent TB allows inactive bacteria to remain in your body, often because the full antibiotic regimen was not completed. The immune system often builds up resistance that reduces multiple bouts with the disease, but it isn't fully preventative against future bouts. The impact of tuberculosis, with over 1.2 million annual deaths, is often compared to the vector-borne disease malaria, about half that, but there are many differences. The similarities are mostly tied to higher risks of exposure for the poor and undernourished in third world countries. Malaria is a parasite spread by mosquito bites, while TB is airborne and a bacterium. Those most susceptible to tuberculosis are the undernourished with weakened immune systems from substance abuse, smoking, vaping, or drinking, and those suffering with HIV and diabetes. Babies are at risk since their immune system is not yet developed, as are the elderly. Overcrowded settings like correctional centers and long-term care facilities heighten the risk. Typical symptoms include weight loss, fever, and cough, making it hard to differentiate from other respiratory infections. Tuberculosis reminds me of the 80-20 rule. 80% of new infections are due to the 20% with active, highly infectious cases. These individuals are called super spreaders. Only about 5% of those infected develop active cases of TB. These factors make screening challenging with some obvious research questions following. Untreated TB suppresses your appetite. Your body ceases basic functions as it injures your lungs and takes the color out of your complexion. The disease was called consumption since it consumed your body as you wasted away. Tuberculosis as an emerging risk is important globally today as an ongoing pandemic, and the trend toward antimicrobial resistance highlights the need for research before the bacterium becomes resistant to antibiotic treatments. Insurers and individuals can put tuberculosis on their list of emerging risks to track for global implications, along with AMR and population statistics monitoring poverty and food security.
All right, Max, it appears that our goals to end TB are significantly off track. What evidence do you see that suggests that a multi-drug resistant strain is becoming a systemic threat to public health system in developed nations rather than just localized outbreaks in high burden areas?
Yeah, it's a mistake to think of disease infrastructure as something that can be managed within the borders of individual countries. Diseases have shown they cannot be contained in this way. TB is active where there's poverty and where medical advice defers to political leaders, who may think of TB as a disease from centuries past, is evolving to defeat current antibiotic solutions and to be multi-drug resistant. This is consistent for TB and other bacteria and shows the importance of continual screening and medical research efforts. If we continue to ignore this risk, it will have negative economic as well as demographic impacts and should remain on a list of emerging risks. NTB efforts are running an uphill battle due to poverty, malnutrition, and overcrowding in areas where TB is endemic.
Well, Max, how do you think that the emergence of new AI-assisted screening technologies change the risk profile of TB as a hidden economic multiplier of disease?
Yeah, this is really interesting. Artificial intelligence can improve screening of chest x-rays to identify cases earlier by not waiting for a patient to be admitted to hospital, reducing costs and allowing radiologists to focus on actual TB cases. AI may be able to be used to identify super spreaders at some point, but society must determine ways to treat these people with dignity to avoid a typhoid Mary situation. Another way to test community TB levels and their trends uses wastewater analysis as an inexpensive way to provide proactive early identification of all types of diseases, although there are challenges for the TB metrics that need additional engineering research. If you can detect cases earlier, you can isolate and treat more effectively and really limit the economic impact.
So, what does the latest data on vaccine trials indicate about the timeline for a viable adult vaccine? And what do you think are the barriers to rapid global deployment once a vaccine is approved?
Dave, a human vaccine being developed by the Gates Foundation is currently in phase 3 trials with a potential release 2 to 3 years from now if all goes well. Initial tests show at least 3 years of protection, and groups continue to be studied as the period from vaccination gets longer. Challenges will include funding, especially in low-income countries susceptible to TB, supply chain infrastructure, and a political interest in the project. The child version is administered separately from other vaccines, so will require additional effort, but overall the prospects seem good that a new tool will soon be added for TB care.
That sounds great. So, Max, how has migrations of populations, particularly people that are fleeing conflict zones in the last 4 or 5 years, impacted the epidemiology of drug-resistant tuberculosis, particularly in Europe and in the West in general?
Yeah, this is an interesting question. When I wrote about antimicrobial resistance in 2022 and 2023, this was a major concern, especially given the recent Russian invasion of Ukraine. The risk I described then was an evolution of infections, which has occurred, but here we'll focus on the movement of infected populations from in or near war zones. This has challenged public health agencies with lack of empathy for outsiders interacting with funding needs. Multi-drug resistant strains are more prevalent in patients coming from these regions, with latent infections reactivating due to the stress of displacement, malnutrition, and limited access to healthcare. Screening requires testing thousands of asymptomatic cases to find one that is active, and multi-drug resistant treatment is expensive and long-term. Immigrants may move again mid-treatment when not completing the entire 6-month course, leaving the patient with a dormant disease ready to come back, potentially having evolved to be more resistant to antibiotics. Strategies, especially in Europe, are evolving as tactics are implemented and tested.
So, Max, this doesn't exist in a vacuum. How do interactions with other risks increase the impact of TB on society?
Yeah, Charlie Munger would call these interactions the Lollapalooza effect. Others use the term force or threat multiplier. TB acts as both a catalyst and a symptom. Compounding vulnerabilities make the net result worse when risks are combined than either could achieve on its own. Another term they use is syndemic. This could be a book. There's a lot of information here, so I'll try to keep it short. Poverty increases the risk of tuberculosis, and TB creates poverty. A double burden occurs from health comorbidity. TB adds on to a compromised immune system due to diabetes, HIV/AIDS, substance use, or smoking. Both morbidity risks must be addressed simultaneously. Climate change destabilizes the social and health infrastructure through forced migration to overcrowded and poorly ventilated housing, and extreme weather disrupts clinics and supply chains to challenge a continuous 6-month treatment cycle. Conflict zones displace population and destroy health services, leading to multi-drug resistant strains that cross borders. There's a stigma to having TB, so many who are afflicted try to delay treatment thinking they will get better on their own, only to increase community spread. TB is considered a historical disease rather than a current one because it is endemic only in developing countries, leading to a feedback loop of underfunding and increased transmission. I think of our recently renewed fight with measles and polio and worry that AMR will lead to a resurgence of tuberculosis even in rich countries, perhaps as soon as the next decade.
So, Max, I next wanted to ask you about leaky houses in a rainstorm, but I know this is a podcast about TB. So, why don't I instead ask you about the difference between a virus like flu and an airborne bacterium like TB?
Yeah, this is fun, but I did not come up with it on my own. It comes from standard public health education. Imagine your home as a house in a torrential rainstorm. The flu is like a sudden violent breach in your roof. It happens in an instant. A shingle rips off or a window shatters. The water pours in immediately and aggressively, flooding the living room within minutes. It's loud, dramatic, and impossible to ignore. Because it happens so fast, you either mop it up quickly or the house is overwhelmed. The flu house doesn't stay flooded for months. The storm passes, you clean up the mess, and the house returns to normal. You likely have some water damage to repair. Tuberculosis, on the other hand, is like a tiny microscopic crack in the foundation that lets in just a few drops of water at a time. You don't notice the first drop. It doesn't ruin the carpet overnight. Instead, it slowly seeps into the wood and the drywall, month after month. You might not even realize it's there until you notice a strange, musty smell in the basement or a soft spot in the floorboards. Because the leak is slow and subtle, the house remains standing, and you continue to live in it for a long time without calling a contractor. But all the while, that constant moisture is quietly rotting the structural beams from the inside out. By the time you actually see the damage, the structural integrity of the entire house is already severely compromised, and the repair requires tearing down walls to fix what has been decaying in the dark for years.
So, Max, I know that you're very interested in the strategies of Charlie Munger. You've mentioned him already. I developed an AI tool that can suggest ways that different great thinkers should think about TB challenges. Can you share what it suggested from Charlie?
Yeah, this is another fun thing that you've put together and we've been able to use for some of these podcast questions. Munger liked to invert the question always and use a lattice work of mental models that would interact. He might say that if our explicit goal was to maximize the speed at which multi-drug resistant TB destroys Western healthcare systems, what should we do? We would ignore wastewater testing, cut funding to border screenings, undernourish our vulnerable populations, and overprescribe standard antibiotics. I would add vaccine development avoidance. As always, Munger describes the risk effectively and succinctly, even if it's a AI version of Charlie. Dave, you led a project during the COVID crisis that dealt with behavioral issues, and it seems like there's a lot of overlap. Can you share some learnings that might carry over? Having been involved in the project, I thought about it a lot while I was working on this topic, and it was not encouraging.
Yeah, sure. The project we did, we called it the COVID Mitigation Monitoring Project. It was an 8-month long research initiative that was supported by the Society of Actuaries that tracked public compliance with pandemic restrictions across the U.S. And we collected in that 8 months about 10,000 weekly volunteer observations. And the project, we tracked behavior across 23 different mitigation options. And I learned that they're called NPIs, non-pharmaceutical interventions, such as mask wearing, social distancing, and restaurant capacity limits. And then we compared the information we got there with the case infection rates that were reported by Johns Hopkins and the CDC. And what we saw was really fascinating, morbidly fascinating, I guess you'd have to say. As you'd expect, communities with higher compliance rates saw significantly lower infection levels. And the overall average compliance rate stayed pretty level, but which things that people complied with changed a lot. And some of those things were much more effective than others. So the takeaways from that apply to this, I think, is that this compliance was not at all fixed. It moved around a lot, and there were the reasons that it moved around seemed to be because people's perception of how risky it was right that minute. So people responded to what they saw locally in terms of infection levels and risk levels, rather than to the news and the national statistics. And people were really, really quick to drop the mitigations when they perceived that the infections were going down. And that caused some really drastic rebounds to infection rates in a number of places. We did see a huge difference between some of the different mitigations as to which were the most effective. And for instance, the one that was the most controversial was mask wearing. Didn't even make the top 5 in terms of effectiveness, according to our study. But the kinds of things that did make a big difference had more to do with the degree to which people gathered together in large groups, and which you'd think of as certainly an important thing. But there was a feedback system going on there, and so as we would look at what we did with TB, that feedback system would be really important to how people would deal with doing things to avoid catching the disease, and also do things to persist in the treatment. It seemed like the information we gathered from that COVID study aren't really encouraging when you think of a 6-month drug treatment protocol that's required to get rid of the disease. The whole thing is that there's a huge human behavioral element in this. It isn't just what the scientists talk about in terms of the aspects of the disease. It really has to do with how people think about the disease and how people think about their risk.
Here are my 3 takeaways from today's podcast. First, TB is an underfunded systemic threat, not a historical footnote. It's a dangerous misconception to treat tuberculosis as a disease of the past, or as just a localized issue isolated within developing nations. With over 1 million deaths annually, its convergence with antimicrobial resistance makes it a highly volatile global risk that demands active monitoring and renewed research funding. Second, TB is a textbook example of a Lollapalooza effect. TB acts as both a catalyst and a symptom, within a wider network of vulnerabilities. It doesn't exist in a vacuum. It aggressively multiplies and is multiplied by shifting migration from conflict zones, climate-driven infrastructure failures, poverty, and healthcare comorbidities like diabetes and HIV. And third, human behavior and perception dictate the risk curve. Managing an emerging risk like TB isn't just about the clinical science. There's also a major human behavioral component. As I found in the COVID mitigation data, public compliance is highly unstable. People drop their guard the moment local threats appear to decline, which triggers dangerous resurgences. With a grueling 6-month treatment protocol required for TB, tracking and managing human behavior is the real frontline defense. We hope that today's podcast has stimulated your thinking about this and other emerging risks. If you like what you heard, please like, subscribe, and share it with a friend. Thanks for listening. Bye.